Ask you please to take your seats. Well, a very hearty welcome to all of you, friends, colleagues, partners. This is the 8th Malaria Day celebration, so to speak. It takes place, as you all know, in a very special year, 2015, when a new World Agenda for Sustainable Development will be decided, and where malaria, among all the health challenges that we need to pursue, will have its place. This is kind of the community working for this, so you all know that it's pretty clear that what we need, increased coverage, better innovation, reaching the unreached, and the commitment of resources and political commitment to do so. So we're really happy it's important to come together and to exchange the information, exchange the key asks, and that's what we do today. Welcome again. We have the pleasure here to have for the introduction our Executive Director. My name is Christian Salazar. I'm UNICEF's Deputy Director of Programs. I will take you through the next 1.5 hours, and without further ado, may I hand over the word to Mr. Anthony Lake, our beloved Executive Director, please.
Thank you very much, Christian. Elizabeth Weiss from AID, thank you for being here. Pedro Alonso. I was going to welcome you and tell you how much I admired everything you have done, both in your vision and in your work on malaria, on vaccines, and especially on reaching the most disadvantaged. But it all got wiped out because we just had a conversation in my office and I discovered that he is a Real Madrid fan. So it is with some difficulty that I welcome you to UNICEF House. I've been working on behalf of World Malaria Day on April 25th since this morning. My first meeting was with the Development Minister of Australia. And I said to him that we're only, 10 days away from World Malaria Day. So you do know, well, actually what I said was, you do know that April 25th is an important day. And he said, yes, I do. And I thought, this is great. We're making progress. The development minister is already getting ready to celebrate. And then he said, of course, it's Anzac Day, the 99th anniversary of the Australian and New Zealand forces fighting in World War I. And I said, well, try not to be too dismissive. I said, well, that's fantastic. And so we agreed, I will celebrate Anzac Day also, and he is going to celebrate World Malaria Day. So if we want grants from Australia, we might pick that day to go to him. Anyway, let me. This is a big deal, and I'm so glad you are all here and welcome. And let me begin with just a few facts, all of which you know, but I think provide a really compelling case for calling attention to, as Pedro and I were just discussing, an issue that is, in a way, one of those wonderful issues where you can tell people things that they didn't know, and then they say, oh, yes, of course, that's more important than I had realized. One of those facts is that every year 10,000 pregnant women die of malaria. Every year up to an estimated 200,000 infants die, probably because the mothers were infected by malaria. And those are appalling, not just numbers, but loss of very human lives. And the point is that pregnant women who have malaria then, as you know, are more susceptible to anemia, passing it along to the infants, to early birth, premature birth, et cetera, et cetera. What's really frustrating is that IPTPs and ITNs, bed nets, can prevent this. And what's even more frustrating is that they don't cost all that much. And this is extremely cost-effective way of dealing with a major problem. And what's outrageous is the inequities in how women are receiving this protection. That 4 out of 10 women, I believe it is, receive the antenatal protection and counseling they need in the rural areas, and 7 out of 10 in the urban areas, which is, as I said, outrageous. And overall, just over a third of women, 38% of women, receive the protection at all. So that's all wrong. And these facts should be, for anybody who listens, a call to action. We know how to deal with this. We know what to do. We can do it. It is cost-effective to do it, and therefore there is no moral or practical excuse for the world not to do it. So I'm looking forward to you all discussing in this meeting how we can all better advocate for IPTP to be and ITNs to be part of not just national strategies, but a funded part of national strategies in their budgets. How we can support communications campaigns that can get the word out to pregnant women about what is available to them to protect themselves and their children. How we can find innovative ways to help the poorest women get to the care centers where they can get this treatment and counseling through vouchers or in other ways. And how, of course, then we can help equip the centers and train the staffs to provide all of this. This is tremendously important, not only because addressing malaria is one of the keys to achieving the SDGs, or the Every Newborn targets for respectively 2030 or 2035, but also just because we are talking about so many lives. I was very struck by the estimate that we could have saved 200,000 neonatal lives between 2009 and 2012. I believe that, yeah. Right, 200,000. Every one of them could be now a child and a future, like my grandchildren and their futures. So this is a wonderful practical cause, and even more a wonderful moral cause when you think of all those children who are not alive today. So thank you. I hope you have a wonderful meeting. I hope you will deeply reconsider your allegiances. And I'm going to sit for as long as I can and listen and learn. And thank you.
Mr. Lake, thanks very much for this introduction. Also, particularly as I know you were about to depart to Washington for the spring meeting to World Bank with quite a tough schedule. So it's really, especially appreciate that you took the time to be here this morning. And without further ado, I'll ask my colleague Agbesi Amuzu. He's in our data and analytics unit to talk about burden of disease and coverage and the data we have supporting all of this. Please, over to you.
Grab your pens, everybody. We're about to learn his password.
Thank you very much. Let me also take the opportunity to welcome you here. to this important event. My name is Agbesi Amuzo. I sit within the data and analytics sections here at UNICEF. I'm very pleased to be able to walk you through some of the latest data on malaria. And before I jump into the burden and intervention coverage, since I won't be able to cover everything, I would like to also direct you to some of the resources that we have here in terms of data on malaria that we compiled here within UNICEF. Then I will talk a little bit about burden and intervention coverage and disparities without really elaborating, because I have other presenter coming who will elaborate more. So we support, as many of you know, many countries, over 100 countries, in the implementation of the multiple indicator cluster surveys to allow nationally representative surveys that collect data on various topics, including malaria. And we have malaria modules that ask questions on preventions, diagnosis, and treatment, especially among children under 5. And so, but beyond that, we work with our country offices to identify all sources of data on malaria, from nationally representative surveys, DHS surveys, or malaria indicator surveys, or other national surveys, and we compile those data into databases that are updated regularly and released publicly on the web. So some of you may have already had access to those databases, but they are, there are several indicators, including internationally agreed indicators on malaria that are extensively used globally for monitoring malaria as well as other programs. They are used, for example, for MDG progress report, the RBM Roadmap Malaria Progress and Impact Series, UNICEF reports, for example, the state of the children, the world children, Countdown, a global initiative for monitor coverage, and some other initiative implemented by governments, partners, academics, and the larger public. So if you are interested in those data, or you need data on coverage of some of these indicators, we invite you to log on or to go on www.data.unicef.org, where you will be able to access and download free of charge all these databases for your analysis. So, in terms of burden and progress, as you all know, malaria remains a disease that we all worry about. If you come from sub-Saharan Africa like me, or you're traveling to sub-Saharan Africa, I'm sure you have on your list how to prevent, avoid malaria. So it's a disease that we care about, and it's a disease of high burden. The WHO estimated that in 2013 alone, close to 200 million cases occurred, which led to about 600,000 deaths. And those deaths are mostly in sub-Saharan Africa, and children under 5 pay the largest tribute to, with close to 80% of these deaths occurring in children under 5. In sub-Saharan Africa alone, where close to the majority of the deaths occur, the burden exists, 14% of deaths in children under 5 are due to malaria. And this varies, the level varies across countries, reaching 20% in some of the countries, which you can see in the darker color in the map, on the map. So, however, I mean, this high burden and somewhat dark pictures is not entirely dark, because there's hope, and substantial progress has been made in the past 15 years or so due to massive scale-up of interventions, preventive interventions, diagnosis, and treatment. We are able to reduce deaths in children under 5 by 40% between 2000 and 2013. And estimate from WHO also show that between 2001 and 2013, we have been able to save 4.3 million lives, and 92% of these in children under 5. So tremendous progress has been achieved, but a lot more remains to be done. So let me talk a little bit about what has been done in terms of coverage. I will focus mainly on preventive interventions, not going too much on treatment or management, case management. But the massive scale-up of insecticide-treated red net since 2000s resulted in also a large increase in the use of IT-net by children under 5. And the map here shows you side by side how trends have moved over time, you will see how countries have become with darker color, meaning that coverage has increased, and particularly in countries such as Rwanda, Burundi, Tanzania, Malawi, Madagascar, Benin, and Democratic Republic of Congo, coverage in the use of ITN by children under 5 has gone beyond over 50%. However, in many countries, coverage remains under 50% and need to be increased. So, as the Secretary Director mentioned, IPTP, intermittent preventive treatment, is one of the effective interventions to prevent malaria in pregnancy. Malaria in pregnancy is essential, preventing malaria in pregnancy is essential because of the adverse outcomes to the pregnancy, to the mother or the baby. So WHO recommend that IPTP be provided during antenatal care visits, and it consists of doses provided to the mother, dispensed to the mother when she makes such antenatal visit. The chart here shows you countries in sub-Saharan Africa that are providing IPTP, and the coverage of IPTP in these countries, which we can see has increased over time since 2000. However, they remain low in most countries. We could commend countries such as Gambia, Ghana, and Zambia, for example, where the coverage had reached over 2/3 of pregnant mothers. But in the majority of the countries, coverage remained under 30% or so. So to the point that we estimated that about 3/4 of mothers are not protected entirely in pregnancy. So malaria. Now, because IPTP is delivered during antenatal care and at successive visits, we looked at the proportion of women who reported having received 4 or more visits, which is a recommendation from WHO to get at least 4 visits during pregnancy. Then, if all these women receive the IPTP or the doses to prevent pregnancy, we should expect that the proportion of women who had at least 4 visits, antenatal visits, should be fairly equal to the proportion that have received IPTP. Well, this graph showing you on the x-axis the proportion that have received 4 in ANC visit, and the proportion that have had IPTP on the y-axis, showing that the proportion receiving 4 or more antenatal visits is much larger than those receiving IPTP. That means that even though many women have reached the health systems, have made up to 4 visits, they still do not get the doses of IPTP that they need to prevent malaria during their pregnancies. So the opportunity to deliver the interventions, even when the woman is present, are being missed and need to be considered for if we want to increase the coverage of IPTP. Not only that, if we look at coverage of antenatal care, most women receive at least 1 visit of antenatal care, but less than 50% across sub-Saharan Africa, on average, receive 4 or more visits of antenatal care. So there's a need not only to maximize the opportunities for women that are coming, but also to increase the coverage of antenatal care, given the IPTP is delivered within the framework of antenatal care. So it's important that both dimensions are taken into consideration. We looked at the equity. So the red is the poorest and the richest, the blue is the richest. And you could see in most countries, we still have a gap with the poorest faring, the richest faring much better than the poorest women in the receipt of IPTP. Now, I want to point out that the 2 countries at the end there, which are Gambia and Ghana, where coverage is high, I mean, over 60%, and there's no gap between the poorest and the richest. So these 2 countries must be doing something right, and probably need to be documented and follow more. But you could see the widest gap in some of the countries that remain to be closed. Now, the other preventive method is the ITN use by pregnant women. And we looked at proportion of women who receive who reported using ITN during pregnancy. And the graph shows you, again, the same, pretty much similar story. Due to efforts that are happening in countries, coverage has increased, but many countries also are lagging behind with fairly low coverage. Some countries have done tremendously well with coverage reaching over close to 75%. Countries such as Rwanda, Benin, Tanzania, Guinea-Bissau, which really seem to be doing fairly well. Now, there is an interesting story that we should also celebrate as a success, in the sense that when efforts are made and poorest population are reached with distribution of ITN, what you start seeing is that even among the poorest population or the rural population, the portion of the percentage of women using the ITN becomes even higher than among the richest population. So here we're seeing that the poorest being the yellow and the richest being the blue. The blue is in below the yellow in many of these countries, showing that really we've really done quite well. We're doing quite well in reaching those poorest women with ITN. We just need to make sure that all of them are being reached in order to increase coverage. So I think my time is up. So I'm just going to summarize here to also highlight the tremendous progress that has been made over the past 15 years in terms of reduction of the burden, in terms of mortality, general mortality, and mortality among children under 5. But the challenges remain: reaching pregnant women and children with the intervention to increase coverage, and targeting these groups within the whole universal healthcare strategy. These must not be left out. Now, this progress have happened because of funding, and fundings continue in order for the momentum to be kept and to be accelerated. Ladies and gentlemen, thank you very much.
Bessie, thanks very much. Our next speaker, I don't think needs really an introduction. I know everybody here and beyond the room. Pedro Alonso, WHO's Director of the World Malaria Program. Please, Mr. Alonso.
Thank you very much. Thank you for the invitation. Clearly, the passion for malaria and maternal and newborn and child health must be one of the most powerful forces that brings us together, and that can even allow us to overcome the deepest of divides between a Barca supporter and a Real Madrid supporter. So I'm delighted to be here, and thank you for the opportunity to share with you some data, some partly already presented, and a bit of a sense of where we are trying to be moving forward over the next few years. So, I presume it's just the next slide. Right, so I'll try to, over the next few minutes, review progress over the last decade, partly already covered by my predecessor here today, and where we're going next. So, by and large, data contained in the World Malaria Report that we released in December this last year in London, and essentially recognizing the progress achieved over the last, we often say last decade, it's truly the last 13 years, and the big numbers are basically this ones. Mortality rates reduced by about half, a very significant proportion of these deaths prevented have taken place in Africa, particularly among under 5 African children. Incidence of clinical episodes down by about 30%, and altogether since the year 2000, an estimated 4 million lives saved. We often term these unprecedented gains, unprecedented results, and I believe they truly are. As many of you will remember, the world embarked in a malaria eradication campaign launched in the 1955 World Health Assembly in Mexico City. Community still discusses whether that was a success or a failure. and a slightly sterile discussion. The truth of the matter is that indeed malaria was eliminated in some countries, but the depth of the gains that we've witnessed over the last 13 years are probably more profound than the gains that we observed during the past eradication campaign. Campaign that was never closed down. The 1968 World Health Assembly actually called for or recognized that the goal of eradication was not achievable in the short term, but would never actually gave up on the final goal of eradication. So, technically speaking, WHO's goal is still malaria eradication. We often use the term malaria-free world, but truly that's what it means. So, phenomenal progress made over the last decade, probably attributable to three major elements. The first one is that the community did recognize that malaria is both a global health challenge and an impediment to economic development. Secondly, that new and better tools were developed by and large in the latter part of the 1980s and during the 1990s, both in terms of insecticide-treated bed nets, new anti-malarial drugs, rapid diagnostic tests, and then thirdly, the substantial scale-up of the core interventions that has already been alluded to and that I'll briefly dwell on in just a minute. So, drops in malaria incidence, that figure on your left, drops in malaria mortality rates, the drops in your right. So indeed, as we mentioned just a minute ago, between 2000 and 2013, estimated mortality rates fell by 47% in all age groups and by 53% in the children under 5. If trends continue, malaria mortality rates by the end of 2015 are projected to have decreased by 55% in all age groups and by 61% in children under 5. Indeed, once again, historical improvements. Figures or graphs like this one may actually hide significant heterogeneity, but what this map shows is that the percentage change in malaria mortality rates between 2000 and 2013, and essentially, if you're on the bluer, those are decreases at least of 75%, in the orange between 25 and 75%, and if you are in the red area, there may have actually been increases. So essentially the progress has actually happened throughout the world. And there are just a few examples, being in the Western Hemisphere, particularly notable the problems in Venezuela, where we've actually seen an increase of about 30% in the last year. One of the champions, you may or may not know, one of the champions of the past malaria eradication campaign, one of the global leaders was a Venezuelan malariologist by the name of Gabaldon, the Maestro Gabaldon, as he was referred to, who basically achieved the elimination of malaria in Venezuela during the eradication campaign. Wherever he is, he will not be very happy to see the current state of malaria today in Venezuela. A place that we do need to pay attention to. The number of cases averted and deaths averted, my colleague has already alluded to. The estimated 4.3 million deaths averted since 2000, 670 million fewer cases of malaria, and again, a demonstration of the massive achievements of the last decade. Now, what are these achievements due to? Well, the right thing to say is, and probably surely true, the scale up of our core intervention. So on the left-hand side, you are seeing something that you should not be seeing right now, because this was supposed to be an animated graph. And in your left-hand side, you were supposed to see what the coverage of ITNs was in the year 2000, and it would be essentially close to zero throughout most of sub-Saharan Africa. And on your right-hand side, you were supposed to see what the prevalence of infection as a surrogate or a measure of intensity of transmission and level of endemicity would be like. And what you would be seeing in the year 2000 was large parts of sub-Saharan Africa in yellow and reddish color, showing a significantly high transmission throughout most of sub-Saharan Africa. If the animation had worked well, I would be pressing the button and you would be seeing how from the year 2000 until the year 2005, not much happened in terms of scaling up of bed nets, which only really took off by the year 2005 and has been significantly growing since then, to end up with this picture where coverage has very significantly increased in a good number of countries. And on the right-hand side, you would be seeing how the prevalence of infection has actually been decreasing over the last 13 years. I would have actually pointed out to you something, and that is that the drops in the prevalence of infection as a marker of transmission intensity predate the scale-up of some of the interventions, or in this case of ITNs. And therefore, it is a reminder that we need to exercise some caution in not to attribute all the gains that we've witnessed to the deployment of, in this case, bed nets. And if we don't entirely understand all the drops that we've witnessed, we should not be surprised to see some increases, as we are actually seeing in some parts of southern and eastern Africa over the last couple of years in malaria incidence. Nonetheless, the figure of 2013 shows that large parts of sub-Saharan Africa have very low levels of parasite prevalence and therefore of transmission, including some of what has often been termed the heartland of malaria endemicity. And basically, three areas stick out, still in red, showing high parasite prevalences, high transmission. Western Africa, including some of the Ebola-affected countries, still some pockets in Central Africa, and then northern Mozambique. That is where we still have our highest transmission intensity areas in Africa. So coverage of bed nets, as my colleague has said, has increased, really taking off in year 2005. It's a big success story, but glass half full, still about 50% of households are not covered with effective vector control in Africa. Indoor residual spraying, a certain tendency to plateau and even at some points decreasing. Good complement to IRS, to LLINs, and we are challenged in WHO to support the Global Fund and generally countries as to how to prioritize where should IRS be deployed versus where should LLINs be deployed. Is there room or need for the combination of both vector control approaches, and if so, where? What is the impact of one of the biggest challenges? The one thing that does keep us awake, but in fact it doesn't keep me awake because very few things keep me awake other than PASA, but insecticide resistance. A massively, I think, unrecognized problem, the one that has the potential to really derail all the gains that we've achieved in the last decade. This is just showing how resistant prevalence resistance to different classes of insecticides commonly used both in insecticide-resistant nets and IRS has been increasing, reaching in some parts of Africa pretty alarming levels, especially so if we recognize that we don't have active ingredients or active compounds that could potentially substitute these failing insecticides in the short term, and understanding the implications of insecticide resistance in public health remains a challenge. There is a fair amount of work going on, most of it actually being carried out by WHO. By the end of this year, we will have a much better indication of the potential magnitude or impact of insecticide resistance on malaria, but certainly a very, very worrying element. IPTP, my colleague has done a compelling presentation. It has become a mantra for us in the last few months. This is a simple, cost-saving, life-saving intervention that implies the administration of a stat dose of SP, ideally up to 4 times during pregnancy, making use of existing health contacts between the target population and the health services. It does reduce maternal anemia. It does reduce placental infection. It does subsequently reduce low birth weight, prematurity, and therefore 2 of the key drivers of neonatal mortality. And we are not doing very well. We are obsessed about all these failed or missed opportunities where the contact between the target population and the health system takes place, but the interventions are not delivered. What are all the determinants? Why of all these bottlenecks? We're not entirely clear. Personally, I think that it partly is because it falls between the malaria program, the antenatal services, the API system, and no one really takes full ownership of this simple intervention. And we are committed to support efforts, and certainly UNICEF is a champion in this, in how do we actually scale up IPTP throughout the endemic parts of Africa. As we speak of this, elimination is the other big word. 19 countries are in the process of pre-elimination or elimination in basically all continents. In the Western Hemisphere, where we are, hopefully this year, Argentina will be certified malaria-free. It is the first country in the Western Hemisphere to be certified malaria-free since the mid-1960s. Something that we should celebrate. Hopefully next year, Paraguay could potentially be certified malaria-free. Central America is making major steps forward. Costa Rica, I think, had 2 cases or 4 cases of malaria last year. El Salvador, about 10. There is no reason why Central America should not eliminate malaria by 2020. And the dream of a malaria-free Western Hemisphere leading the global effort is one that does remain very close to my heart. Funding, great progress. Again, since the year 2005 up to the year 2013, you won't be able to see from the back. I cannot even read it from here. But essentially, the different sources of funding. A continuous increase with a certain tendency to plateau over the last few years, and totaling close to $2.5, $2.6 billion made available for malaria control last year, 2013. If we look at the breakdown between domestic funding and international assistance, or ODA, for the African continent and other WHO regions, we notice that there is still a massive disproportion between the ODA, the external support, versus the domestic funding in Africa. That ratio is smaller in areas outside sub-Saharan Africa, but to me the negative message of this graph is that over the last 10 years, domestic funding in sub-Saharan Africa has not really increased, and nor has it increased in countries outside Africa. Some of these countries, remember, 6 out of the 10 fastest growing countries in the world are in sub-Saharan Africa. Some of the most powerful economies are sitting in this place. There is something that we are not entirely understanding, and we're not doing well if we cannot get those countries to really mobilize their own domestic resources. My guess is that as we look over the next 15 years and the type of resources that we will be requiring, most of them will need to come from domestic funding. My guess is that no one's going to pay for Brazil to eliminate its malaria, or, but frankly, for India, let alone for China, and let alone for some of the fastest growing economies in the world. They will need to pay for this, and understanding the mechanisms of how to unleash domestic funding, I believe, is going to be critical for us moving forward. So, just a few facts, and you've heard a lot about this. Still half of the population at risk do not have an ITN. Still 15 million pregnant women do not receive IPTP. We must absolutely correct this scandalous figure. Still 60 million children do not receive, are not diagnosed. 60 million cases of malaria go undiagnosed and untreated. When we, rightly so, place a lot of attention to the problem of artemisinin resistance or multi-drug resistance, there is no worse case than actually the fact, actually recognizing that 60 million cases of malaria go untreated. Not with a drug which may have resistance, with no drug whatsoever. We need to correct that. So, what is WHO and the broader community proposing? Over the last couple of years, we've been working to develop the so-called global technical strategy for malaria, to give ourselves to cover the 2016-2030 period. Why do we need a new strategy? Well, still over 3 billion people continue to be at risk of infection and disease. And we are therefore still far away from regional and certainly global eradication. Major global commitment is needed to continue scaling up the interventions and close the gap, the unfinished agenda, which remains massive as we tackle the two key biological threats that we face, drug resistance and insecticide resistance. We believe that new guidance is needed to address the heterogeneity of malaria transmission and endemicity. We often use the sentence, there is no one-size-fits-all approach in malaria. We need to stratify. We need to understand the heterogeneity, the variability, and adapt our responses to the changing epidemiology of malaria. And therefore, we believe further guidance would be needed. The next few years may be years in which we realize the promise of new transformative tools for malaria control. And not just tools, but new strategies and approaches of using the new and the old tools to accelerate in our effort towards elimination, and that will include certainly addressing the issue of asymptomatic infections. Finally, in a world where we will have SDGs and all sorts of targets and indicators, we believe that having a clear vision with goals for the post-2015 period would be a useful exercise. As such, we have developed, following a very intense process of consultation and engagement with broader community, and most importantly with the countries themselves, a global technical strategy for malaria. This should help prepare the ground for an accelerated effort with a renewed focus on elimination. It urges endemic countries, donors, and stakeholders to maximize the impact of existing tools and strategies until new and improved tools become available. Builds on 5 core principles, which are not intended to just be politically correct or pay lip service, but really root our strategies around the concept that all countries, irrespective at which level of endemicity they are, can actually accelerate towards elimination. Secondly, country ownership, a much used word, but often ignored. There will be no elimination of malaria in any country if it's not actually done by the country themselves. And I know this sounds phenomenally obvious, but practice tells us time and time again how there is a certain tendency to actually bypass governments or national malaria control programs on the grounds that they're not very well performing, or there's a history of mismanagement of resources and so on. We need to try to help them fix that problem. But there will be no elimination, there will be no real progress if this is actually not owned by countries. And I'm happy to see here Justin Cohen from the Clinton Health Access Initiative, because I think they fully endorse and embrace that notion, and that's why they actually work by embedding people into the country programs themselves to actually help them become more functional and better performance, and we applaud that effort. Third key building principle is we need surveillance, monitoring and evaluation. Believe me, it is slightly embarrassing when we, I'll tell you here, and we won't tell the folks out there, but when we present our World Malaria Report and we present all these figures and so on, let us just be clear, most of it is the product of modeling. We still don't have real data. And most importantly, countries don't have real data for them to primarily use it for better planning, progress tracking, and adapting their own strategies. The next few years must be about generating data in country, primarily for the use of the country itself. The fourth is equity in access to services, especially for the most vulnerable and hard to reach populations. Elimination will not happen, and this is a key mantra for us now in the greater Mekong sub-region, a focus of our work to support an elimination effort in that region. If we don't provide free medical care to the migrant, mobile, displaced population without the risk of retaliation or deportation. It will simply not happen if we don't tackle that. So reaching that, those populations will be important. And finally, innovation. And I think it is very important that on a WHO document, we fully, on a new strategy for malaria, we recognize that we will not make the mistake that was made in the 60s, in the first malaria eradication campaign, where someone, an illustrious malariologist later on, well, the malaria eradication campaign failed to eradicate malaria, but nearly succeeded in eradicating malaria research. We cannot afford to make that mistake. We need the products of innovation throughout the process of accelerating to improve control and elimination. Strategy builds on 3 blocks, what we call Pillar 1, ensuring universal access to malaria prevention, diagnosis, and treatment, the core WHO recommended malaria interventions. Pillar 2, how do we adapt strategies to accelerate towards elimination and attainment of a malaria-free status. And the Pillar 3 is really transforming malaria surveillance into a core intervention itself to supporting elements. one, harnessing innovation and expanding research, and secondly, strengthening the enabling environment, which is not just about advocacy, it's about the regulatory environment, many other things that need to happen in a country for us to be able to move forward. Our vision, contained in the global technical strategy, is a world free of malaria. As we said, this is no different to what was said in 1955 and in many ways retained in the 1968 World Health Assembly. We do envision eradication of malaria, a malaria-free world. Our targets for 2030 is that we will have reduced by at least 90% disease and death, that at least 35 new countries will have actually eliminated malaria, and we will have avoided re-establishment of transmission in those countries where malaria has been eliminated. And then we've wanted to make 5 years milestones to allow us to track progress. And frankly speaking, for us, the 2030 targets are very important, but we want to focus on the 2020 ones, because that's what we need to achieve in the next 5 years. And that calls for a reduction of at least 40% in disease and death due to malaria, and at least 10 new countries having eliminated malaria. Now, you may rightly ask yourself, are these the type of aspirational goals that were often included in the MDGs? More to mobilize resources, to act as advocacy pieces rather than real data? Well, this was a very deliberate decision that was taken at the very beginning of the process. No, they are not aspirational. They're not to be advocacy pieces, but actually rooted in real data. So let me just sort of share the approach that has been followed in developing these targets. First of all, a review of the trends in malaria cases and deaths in the period 2000-2012, and what would happen if we actually continued in that line of progression. Secondly, a review of the targets that national malaria control programs have actually established themselves. This is not us telling them, this is what they actually do. And thirdly, mathematical modeling on, and this specifically just on falciparum malaria. Now, if you just bear with me a couple of extra minutes, so sorry, just to say, I mean, somehow the triangulation of all these elements is what gives rise to the targets that you've just seen. Using currently available tools. In other words, we believe that these may actually be conservative estimates because they don't factor in the potential impact of the tools that we hope to have within the next 5 years or so. Couple of different scenarios, or 4 different scenarios. What happens if we just sustain the current coverage rates at the current levels? What would happen if we actually scaled up to about 80%? What would happen if we actually scaled up to about 90%? And what would happen if we actually went back to the 2007 coverage levels? Now, the reason to show this graph, which is not contained in the global technical strategy, although there is wording that alludes to this, is that this is clinical malaria and this is mortality. And the basic message, which we suspect is right, is if we just remain where we are today, with the type of coverage levels that we've achieved up to now, and this great scale-up that we've seen, what we should expect is actually an increase in malaria and an increase in mortality over the coming years. If we actually revert to the 2007 levels, this is what we should expect, a massive rebound both in disease and death. To me, the take-home message is there is no option of staying where we are. We simply just have to accelerate, because staying where we are will actually take us back. So we need to pedal faster, because pedaling at the speed at which we're pedaling will make us fall. However, if we accelerate and increase coverage to 80%, these are the gains that we could achieve, and if we accelerate it to 90%, these are the gains that we could achieve. So this strategy has been completed. It's a relatively short document, has gone through a very intense process of consultation, which has been important because it has led to significant ownership by countries and regions. It has gone through the executive board this past January with very strong support from countries. Veterans tell me pretty unprecedented support that was witnessed last January. And we're looking forward to this being formally endorsed by countries in the World Health Assembly that will start in Geneva in just a few weeks from now. We hope to have a side event organized by a good number of countries: South Africa, China, Thailand, Mozambique, Brazil, and others, to celebrate the launching of this new strategy, as well as launching the new regional innovation strategy for the greater Mekong sub-region. So let me stop here. Let me thank you for the opportunity of sharing all this data. We all share the passion for malaria. We all share the need to work in partnership, and particularly the partnership with UNICEF is a very dear and needed one from us at WHO. WHO is only one part of the larger group of people and institutions that need to work together to eventually imagine and hopefully realize a world free of malaria. Thank you very much.
Thanks very much for the bird's-eye view on the situation and also the strategy for the coming years. Just picking up on what you mentioned, importance of domestic budgets. This week, as you may know, member states are negotiating the outcome document for financing for development, and we very much hope, and together with WHO other partners, to be able also to make the pitch for the investment case on health, education, protection, other areas that are important as we prepare jointly for Addis Abeba. And you mentioned in your final word the importance of partnerships, and that's our next topic. Welcoming very much Elizabeth Fox. She is the Director of the Office of Health, Infectious Diseases and Nutrition in USAID's Bureau for Health. And without further ado, give you the word. Please, welcome.
Thank you, Christian, and thank you all. I'm really thrilled that I can be here today to talk about partnerships. And I think, Pedro, your presentation shows the importance of partnerships and the importance of us all being under a same mission and goal in this. Happy to be here with WHO, to be here with UNICEF and JPIGO and NGOs here, and lots of other partners. I'm also honored to represent USAID and the President's Malaria Initiative, which has been an amazing partnership. And it's worked because it's really grounded. And it's worked because it's grounded starting with the countries. Things aren't going to work if we're not starting with the countries. We've seen that in terms of the need for domestic resource mobilization. We've seen it with the need for true partnership. But also there are a lot of other partners out there, in the Global Fund, and WHO, and UNICEF, and NGOs. We pretty much partner with everything except the mosquito. And we might do that someday. Thanks to these partnerships, we really are making progress. I think we've seen that today with your data. Thank you. It's impressive, but it's also scary because we could lose that momentum. And that's why partnerships are so necessary. And we still have a big problem. And we have a big problem, especially for women and children. Not only women and children, but the poorest of the poor. And that's who malaria is affected by. Despite all the progress we've seen, we still have a large amount of under 5 mortality. 3/4 of that mortality is preventable, and it's preventable with things we know how to do. Diarrhea, pneumonia, malaria, newborn death, low birth weight, these are all preventable in many ways. Malaria is probably the easiest, and it's what makes us maddest when we look at the prevention and the techniques that are out there, and the fact that some of these are not accessed. Especially the issue of low birth weight. We have tools. We have simple tools. We have proven tools. We have tools that are acceptable. Why isn't it happening? I think this is a question that bedevils us all. You talk about access, and we see these very impressive figures on actually women going to get antenatal care but not getting IPTP. Really good question. And I think as a partnership, we don't have the answers. What we do know, and we're beginning to see, also through partnerships, is that the solution to a lot of these questions or these doubts isn't really at the service level. It's probably at the community level. And it's probably at a level of beliefs and behaviors and the work of community health workers and community members, which are also our partners. And that's why I think it's important today to also pay attention to the amazing work that's been done with the integrated community case management work, especially around malaria, and how that's been used to work to get many of these essential interventions to the people who need them the most. These are preventive measures that can be accessed in a lot of cases without access to services. And the fact that community health workers and communities mobilizing on their own can do a lot makes a big difference. The ICCM is a great example of partnerships, and PMI has been working a lot with that, and so has USAID. And we see that in terms of the work with community health workers in Ethiopia, in Rwanda, in Senegal, in Malawi. Some of the countries where we've got real progress, we can really see the impact of working through communities and working through community health workers. You need different partners to think differently about strategies. And you need different partners to do different things. And I think that's one of the things we're going to see with the strategy going forward. To achieve these goals, we do have to be all pedaling that bicycle really fast, but we do different parts of it. And seeing how those different parts come together is an important work to do, and it's an important work to have under a general framework. The fact that some partners are better at the community level, some are working fixing supply chains, some are working on commodities, some are looking at what's happening with women and access to services. Different partners do different things, and USAID certainly works in many ways through PMI and through all our partners with those different functions. For example, in 2014, last year, USAID and PMI trained 85,000 community health workers. It's a lot of community health workers, especially thinking of all the people that those people will reach. And that's on administering diagnostics and preventive therapies. They don't just do that. When you speak to a woman, when you go into a house in a village, you talk about a lot of different things. And you also have a different message in terms of what health is all about, how you can address a lot of your own health issues at an individual level or a community level, and how some of these behaviors and some of these beliefs around providers, for example, are very deeply rooted in communities. We've all seen that. We've all seen that recently. And I think it's why working with community health workers and working at the community level is a real advance in that. ICCM is a great partnership. It's not the only one we work in. As I said, we work with every partner except mosquitoes. The Newborn Action Plan, I think, which is very closely tied with sort of the goals of what we're talking about today and the group that's here, is another fabulous partnership. It wouldn't have been written without all the partners here present and many more, and it wouldn't have been adopted at the World Health Assembly. So we're grateful for that and grateful for that partnership. This plan allows us to work together to build platforms, lots of different platforms. It also helps us on the monitoring and evaluation. And I think that's where our data will start being real data. We can move beyond modeling in many cases when we start working with countries themselves on scorecards. When we have the type of data that actually tracks progress on these different interventions and can be applied more strategically to help us adjust our work along the way. Modeling data is great. It gets us energized. It makes us look for the future. It doesn't solve your day-to-day problems on what you change. And so I think working with scorecards and the platforms from the Every Newborn Action Plan is going to make a big difference. And it looks at simple actions. It looks at actions like behaviors, and it looks at actions that work with newborns, breastfeeding, washing your hands, kangaroo care, things that are part of saving a newborn life and also are going to reduce deaths and newborn deaths across the board. Working in partnership is what we do. We also, for lots of reasons, because we're impatient, because we've seen this happen before, because of pressures from outside, we keep a pretty relentless eye on impact. And I think we all have to hold ourselves to that. As a partnership, we can't just be happy together, we also have to hold ourselves accountable. And I think that's one of the real points of convergence around having an overarching vision and having a strong partnership statement. I think only through that are we going to reach that grand convergence, be it 2030, 2035, where every woman and every child has an equal chance, an equal shot at a healthy life and a productive life. And malaria and its impact on health, on behavior, and on economies is going to play a very important role in that. And that's why I'm so pleased to be here today to speak about partnerships. Thank you.
So thank you very much indeed. You know, a lot of the successes, the great successes achieved due to the country ownership, to the decisive government's decisions, but then due to the partnerships around it. Without that, we all know that nobody can achieve. And also for the future, that will be a decisive, and that's a nice swing into Valentina Buch's presentation about the challenges, because there are still, as we have heard also from history, a lot of challenges. In UNICEF, at least we say that like reaching the last 10%, so to speak, we're not even in that situation, is probably harder than, you know, reaching the first, say, 80 or 90% of children with whatever service. So the challenges are huge still, and my colleague, the global advisor on malaria, Valentina, will talk to you.
Thank you, Kristen. I won't need to reintroduce myself. I'm Valentina Buch, and I have the pleasure and privilege of being UNICEF's Global Malaria Advisor. So as I think everyone has presented, the big problem with malaria is that it is very much a disease of the poor, and it is poor rural women who are the most disadvantaged, and those that we are having the hardest time getting access, ensuring that they have access to intermittent preventive treatment and to bed nets. I think everyone's talked a lot about this, so I'm going to give you a couple of numbers. The problem is not just that it's 125 million women who become pregnant every year, and the number is so high because, as Pedro reminded us, India is also a malaria endemic country, and so a lot of women are becoming pregnant and are exposed to the malaria parasite. And as also has been discussed, the problem is that it's not just the women who die and their newborns who die, it's when you're born low birth weight, those effects are long-lasting. It's a developmental problem that can affect you your entire life. It affects your chance of thriving, it affects your access, it affects everything that will happen to you later in life. We've discussed that there's actually for malaria and pregnancy, and scaling it up, there's two different arms. There's bed nets and there's IPTP, so I'll start with bed nets. Pregnant women are really reached best through routine systems, and for that we need strong health systems. UNICEF supports bed net distributions at antenatal care and also at immunization contact points. UNICEF is also doing a lot of support for mass campaigns, which sometimes nets pregnant women, pun intended, but it is not sufficient, and I'll tell you a couple of numbers in a minute. We have a long way to go. I think Pedro did a beautiful job of sort of saying we have opportunities, we've come a long way, but if we take our eye off the ball, we're going to go into a huge sequence of problems. Evidence has shown that of the 75 documented malaria resurgences, the majority are linked to decreased funding. And this little curve scares me. The decreases in funding hit pregnant women particularly hard. A case in point for me that was very close to home is in Madagascar, the coverage of pregnant women under nets was 72% in 2011, but by 2013 it had decreased to 61%. And this isn't the only country. Other countries that have seen similar drops are Niger, Kenya, and Nigeria, and many of these are linked to decreases in funding. So if we're going to talk about IPTP, I thank Elizabeth for really setting the stage that it is about partnerships. Pedro also said it, IPTP is the lonely stepchild because it sometimes falls between the cracks of reproductive health and malaria. Both of them say, oh, no, the other group will take care of it. And if we don't focus on really having partnerships working across nutrition, HIV, health system strengthening, and communications, and as Pedro said, showing the impact of that partnership, we're not going to get the focus scalers that we need. Like Bessie showed the problems that we're seeing here and the horrifying statistic that only 23% of African women are receiving the recommended dosage. When you combine this with low levels of LLIN coverage amongst pregnant women, we really are missing an opportunity to protect women and to scale up and move on those first steps towards malaria elimination. It's cheap. This is what really scares me. It is very, very cheap. The full 4 doses of IPTP cost less than 50 cents. If you already have an existing ANC platform to add IPTP, it's $1.10. How many of you bought coffee this morning? I had to pay a lot more than $1.10 this morning. So it really is an incredibly missed opportunity. And bed nets, we have an extraordinary opportunity. Bed nets, including delivery now, are about $5. Again, less than that specialty coffee this morning. So if we could really work on spending less on coffee and more on IPTP and bed nets, I think we could reach a historic achievement. For me, what's incredibly important is a bed net, it lasts for 2 to 3 years. So we're not only covering that pregnant woman, we're covering her newborn and possibly her second child at that particular point. So it really is an incredible opportunity. Challenges. We like challenges in UNICEF. Again, here the problem is who's going to take care of it? Everyone says the National Malaria Control Program, then we push back to the reproductive health, and we're sort of pushing back and forth. But at the end of the day, it's the woman who has to walk to that health facility. It's the woman who has to sit there and then be sent home with no IPTP. Part of those are barriers because she's poor. So if we're not giving the service for free, or we haven't paid for those 50 cents of 4 doses to be free, she can't access it. So the problems really are about money, but sometimes, oops, moved too fast. But sometimes it's also getting to the community, passing on messages, ensuring that there are no taboos about a pregnant woman going to a health facility by herself, ensuring that she has information about how many doses, what are her rights, incentivizing community health workers. So we have to ensure that community health workers are retrained. And again, I thank Elizabeth for saying that we trained 85,000 health workers. We still need to ensure that they're well trained and that they understand and that they have the drugs at their disposal. We also have to train them on quantification. Much of the data that I collected for this presentation from country offices, they said, you know what, the problem was we had enough to give maybe 1 or 2 doses. When we have to go to 4, we don't have enough drug. We didn't do the numbers right. So again, we need to go back to that community level and ensure that we're getting their data. Pedro says it, and it's our mantra: surveillance, reporting, data, and feedback loops. Ensure that it's the community who knows what to do with the data that we're collecting. This is a problem that gets to me quite a few times because, yes, universal coverage is incredibly important, and so are campaigns, but you can't take my routine nets. You can't disadvantage people. So often the campaigns come through and they will just say, okay, we've got these nets, we're supposed to be distributing them next year for pregnant women and their kids. We'll put them in the universal coverage campaign and our numbers are set. But the next year there's pregnant women who were by themselves, who weren't married or maybe not pregnant, and they don't have the opportunity to get a bed net. So we really, again, need to make quantification. And again, that dedicated financing for malaria and pregnancy interventions, which are IPT and the bed nets, and don't take my routine bed nets. So I thought I would show you what it feels like for a pregnant woman when she's pregnant to have malaria.
maladie active.
I'm going to finish that story in a little minute. So long as you could read what she was saying. And what I love about that clip is that she says, my life was not over. I might have had malaria, but my life was not over. So what are we going to do going forward? We have a lot of opportunities and we have priorities, but amongst them I would like you to really keep in mind that we're going into a resource-constrained environment, which means we need to ensure and focus on vulnerable populations. We need to ensure that we're looking at every opportunity, which involves expanding the delivery base. We're going to have to think innovatively, think about using public, private, and faith-based health facilities. Sustainable financing. The Global Fund has changed to a new funding model, which tells me I should have some ideas about how much money is coming. But I still need to ensure that that's being dedicated and going towards these vulnerable populations. And we need to do outreach activities. Again, that partnership at the community level, ensure community health workers and supply chains and procurement systems are well aligned to get to this community level. We also need to ensure communications, which means proving that when we do this outreach, we are reducing ignorance and stigma, and we have to think about incentives. There has to be an incentive for a woman to walk those 5-10 miles to the health facility. We have to ensure the community health worker is there and is trained and can help her. And to that end, I think we need to start thinking about mHealth. mHealth is really a very good way. There are opportunities and there are initiatives to send out SMS to remind a woman when she's supposed to come for her ANC. But the other thing that UNICEF is working on is quantifying and saying, look, you can tell when a clinic is stocked out. You can send information back to the capitals to say, this health facility didn't have any drugs. Please send us more supplies. There's 6.2 million phones in Africa. It's the fastest growing coverage rate of mobile phone use in the world. I think we need to really use that opportunity. So let's sustain some gains. What is working? See? Chris is telling me his phone is working. I need to get that working for pregnant women as well. We talk about partnerships, and I think we really do need to ensure that that continues forward. We have an incredible comparative advantage. We have ability to deliver on the ground. We can use these partnerships. We have right now a UNICEF Global Fund MOU, which is focused not only on community health, but also on the maternal platform. We need to leverage that to ensure that we're delivering. And we can also use maternal and child health weeks. It's a fantastic opportunity to really use that campaign mechanism, not to steal the routine meds, but to deliver drugs and to deliver bed meds. And this is what we stand to gain. This for us is incredibly important. We can reduce low birth weight, we can reduce perinatal and neonatal mortality. We can save more mothers' lives, which will save their children's lives. And we can start these steps on the road to malaria elimination, as Pedro pointed out. So I'm going to finish Sabine's story for you.
On nous a montré comment on devait le placer pour dormir. On a su placer, maintenant on a commencé à dormir sur le moustiquaire. Et à partir du moment où on a commencé à dormir sur le moustiquaire, on a pris la maladie, le palliatif. Parce qu'avant, si tu gagnais un peu d'argent à cause du moustique, si tu as eu le palliatif, tu gagnes un peu d'argent, tu es obligé d'aller à l'hôpital avec. L'argent qu'on devait aller à l'hôpital avec, on garde pour la nourriture. Puis s'occuper des enfants, s'occuper de nous-mêmes aussi. Donc je suis très content de ça. J'ai dormi maintenant à sécurité, mon enfant et moi et mon mari.
And with that, I thank you.
Valentina, I beg a little bit of patience. We're running a bit short of time now, so I think we have one more speaker. That's Elaine Roman from the HPIGO's malaria team, the lead of the team, and also I understand co-chair of the working group on worldwide malaria and pregnancy. Kind of taking off from where Valentina just ended, please, the words for you.
Well, good afternoon. It is a real pleasure for me to be able to be here today with all of you to talk about the global rollback malaria call to action for intermittent preventive treatment. I am so honored to be speaking with this esteemed panel, and it is really for myself, who's been working in malaria and pregnancy with many of you over the years, to see the commitment now and the partnership coming together to raise awareness around what we need to do to move malaria and pregnancy forward is so, so important. Let me just mention up front very, very quickly a little bit about how this call to action came to be. And we've heard a lot already about the burden and the reality of where we are today with malaria and pregnancy. And in November of last year at the American Society for Trout Med and Hygiene conference, a number of global and country level stakeholders came together in a seminar to really initiate this call. And from that time, a group including the Malaria and Pregnancy Consortium, JPIGO, the London School for Trout Med and Hygiene, worked very closely with the World Health Organization and a number of other partners to get us here today in time to launch this call. So I included two facts up here, two sobering facts, and in fact, Pedro's talked about them, Valentina's talked about them. I think we heard about them in the first presentation as well, but I think they're worth reinforcing. These are sobering facts. The 2014 World Malaria Report states that 15 million women of 35 million did not receive one dose of IPTP in 2013. That is unacceptable. We have to do more, and we have to do better. We heard also that up to 200,000 infants are estimated to have died as a result of malaria and pregnancy. And again, as Pedro said, these lives could have been saved between 2009 and 2012 if we had achieved the RBM target goals for 2010, which incidentally were at 60%. But even with those facts, even with where we are with the burden today, now is the time, there is real opportunity to turn the tide for malaria and pregnancy, and we can do more. It will take partnership and commitment from countries to make sure that the WHO 2012 recommendation for IPTP is realized, not just through policies, but also through successful implementation. We also need to commit and support health system strengthening, especially antenatal care, where most women are coming to receive IPTP. As we push forward to achieve in the final steps towards the Millennium Development Goals, this needs to continue to be a prioritization, and also as we move forward to the Sustainable Development Goal number 6 in the future. So every call to action has a plan and a time frame. And I want to remind us too, and we've heard this morning already, malaria and pregnancy is a maternal and newborn health issue. That is clear. And so the ultimate goal of this call to action is to ensure that the adverse outcomes of malaria and pregnancy are eliminated. And we're going to do that by increasing IPT coverage. And let me say, that doesn't mean that we're ignoring net coverage. We're not. But if you look at the trends in net coverage and you compare them to the trends in IPT coverage, there is quite a remarkable difference. So we really need to push forward for IPT. I won't go through all of this, but a key next step is really going to be gaining buy-in, gaining support, commitment from countries to accelerate this further at country level, on top of what they're already doing. and achieving by our target by 2030 that at least 90% coverage with 3 or more doses of IPT in areas of stable malaria transmission. So over the next few slides, I just want to quickly talk about a few of the select recommendations that the call to action makes among a variety of stakeholders. Some of these have been discussed already, and I'm not going to mention all of them on each slide in the interest of time. There has been a lot of valid and important points around partnership, and I'm so glad to hear Elizabeth talk about partnerships. It is absolutely critical for malaria and pregnancy. As a maternal and newborn health issue, it is reproductive health programs that need to carry the flag and push this forward. And yet malaria is largely funded through malaria programs. So supporting and strengthening these partnerships at country level to ensure that planning is coordinated and efforts are not duplicated is absolutely critical at this time. Also, exploring alternative opportunities for the delivery of IPT in communities where antenatal care may be hard to reach, or as an extension of antenatal care. At the donor level, I talked about health system strengthening, that continued commitment to strengthen health systems, and especially around antenatal care, as well as promoting the inclusion of IPT in grant proposals. We should be expecting in endemic countries where malaria exists that IPT, malaria and pregnancy, is included in that proposal, not just for improving malaria outcomes, but for ensuring that pregnant women and their newborns have better lives. In the research community, validating findings, validating what we know works. There are a number of country success stories in the malaria and pregnancy community, but they're usually typically in smaller, pocketed geographic zones. And so these need to be validated with further research so that they can be replicated, so that they can be scaled up, so that we can achieve coverage. As well, and linking back to what I said on the first slide, it's evaluating those alternative strategies for the delivery of IPT in harder to reach populations and communities. In the pharmaceutical industry, meeting the demand for SP. We know with the new recommendation that we need more SP, and this was discussed, and Valentina made this point as well. It's also affected by many countries are now supporting seasonal malaria chemoprophylaxis, which uses SP as well. So the supply is limited. We need to ensure that the availability is there at antenatal care clinics. In civil society, advocacy and promotion for the importance of IPT, as well as holding governments accountable in their countries to deliver IPT to pregnant women. So I wanted to share many successful stories with you today, but in the interest of time, I'm going to share one, and it's about Ghana, because honestly, this day is about harnessing our power of working together, but it's also a celebration in what has come so far. So Ghana, I think many of you know, made a remarkable and notable increase in IPT in a relatively short period of time. As background, Ghana adopted a 3-dose policy of IPT in 2004, and they adopted a 3-dose policy which was unique to most African countries at the time. The only other country that did that was Zambia. They did that because of the high prevalence of HIV. And then over a 3-year period, they increased, or IPT uptake increases 2 doses of IPT from 44% to 65%. In addition, Ghana has very high rates, or has higher rates of 4 or more visits of antenatal coverage. And this is important because while most women in sub-Saharan Africa, and we heard this earlier as well, will come for at least one visit and often 2 visits, the numbers really decline after that second visit, as we know. So Ghana had this really unique backdrop. It had a frequent dosing policy of 3 doses, and in addition, it had fuller coverage of antenatal care, or comprehensive coverage of ANC. So the question was, well then what did Ghana do against that backdrop to actually increase IPT? And we reached out and we spoke with USAID, we spoke with PMI, we spoke with supporting partners, we spoke with the ministry, both the reproductive health team as well as the malaria team. And this is what we found. There were initially 4 key elements or key pieces to helping Ghana to increase IPT coverage. The first, and really the underpinning, was that partnership between reproductive health and malaria control. They worked together, they sat together to ensure that implementation was planned and coordinated, and more importantly, that efforts were not duplicated. The second piece was around increasing demand at community level, focusing messages on increasing IPT uptake, but as well increasing ITN coverage and early antenatal care attendance. The third piece is the capacity development piece, and Ghana really did this in a comprehensive way and still has a focus on this in ensuring strengthening pre-service education at the national level, in-service training at the district and facility level, and then following that up with mentoring or supportive supervision to providers. And the fourth piece, which they initially had a real challenge with but overcame, was ensuring the availability of SP at the antenatal care clinic, at the point of care, which required monitoring those stocks at facility level, district level, and national level. And unfortunately, I'd like to say this is obvious, but that is not done across many, many countries. We still are seeing stockouts of SP at antenatal care, and they sit in a warehouse at national level. Not acceptable. So it was these 4 pieces against the backdrop that they had that really helped to push Ghana forward. And I think this is really important for why we're here today. It's important because now countries have adopted, or most countries have adopted, the new frequent dosing policy. So now this is affording countries, or will afford countries as they move forward with implementation, the opportunity to increase uptake of IPT. I would like to encourage you all to go to the call to action site through the link here. There's also a social media kit that promotes messages around this. We also have handouts, copies of the call to action on the table right when you came in, so please pick one up. This is an advocacy document, and it's only going to be, the more that we can push it, the more that we can get the word out, that we are going to help to accelerate efforts going forward. And finally, I would like to acknowledge the organizations listed here, and one is missing, USAID, but that's part of the President's Malaria Initiative. But thank you.
Thank you very much, Elaine. I would like to close this meeting now, and first of all, by thanking all the panelists for joining us today. And we haven't lost a lot of public, even though we went a bit over time, which shows, the commitment and interest in the topic. Thanks all for joining us. This whole meeting will be uploaded on YouTube, so you can look at it or get back to some of the details, or watch yourselves if you want to. And I would also like to reiterate the invitation at the beginning that a lot of the data presented are on data.unicef.org, so for those who really want to go into the data more, please do visit the website. And then even though Valentina has urged us to spend less on coffee and more on malaria, we are still offering some coffee over there and some bites if you would like to. And again, thanks very much, and we have a lot to do in the coming years. We very much hope that really for Addis Ababa can only reiterate, and and also for the SDGs and all the work that is really, a lot of us, if not all, are concerned with not only the financial ask, the indicator work, etc., etc. There's a lot of going on right now, and need to stick together and work towards these common causes. Thank you very much.